All right, so my name is Russ Derry. I'm the Director of Education at Epilepsy Foundation of Michigan, and this evening's Learn and Share conference call is on epilepsy decisions, how to make informed choices. And we're very happy to have with us today Dr. Rachel Fabris, who's an epileptologist with Spectrum Health. So Dr. Fabris, can you please just share a little bit about your clinical and research interests and also your experience with this topic?
Yes, so just a little bit about myself. Like you said, I'm an epileptologist, which is a neurologist who specializes in epilepsy. I did a neurology residency as well as epilepsy fellowship at Mayo Clinic in Rochester, Minnesota. Right now I'm working, as I think you said, at Spectrum Health in Grand Rapids, Michigan. All the time I see patients who have a new diagnosis of epilepsy and also those who have had epilepsy for many years. And so I'm aware of all the decisions that a person needs to make regarding their epilepsy treatment. I have a particular interest in women's health, and so I understand the particular obstacles that women with epilepsy face and also the unique circumstances that they need to consider.
Great, great. So as you referenced, the call will be talking about all the different decisions that are faced by people with epilepsy. So as the number of healthcare and diagnostic and treatment options increases, so does the number of choices that people with epilepsy and caregivers have to make. And there's also numerous decisions to be made regarding health information, insurance coverage, employment, school, driving, and many other issues. And just the sheer number of decisions that need to be made and the massive amounts of information to sort through in making these decisions can be overwhelming at times. So on this call, I'd like to discuss some of the most common and important decisions that people with epilepsy and caregivers are faced with, what factors should be considered when making these decisions, and then some general tips that can help people to make informed decisions without getting unnecessarily overwhelmed. So let's start by talking about medical care. So over the past 50 years or so, there's been a major shift in the respective roles of doctors and patients. And the relationship used to be more paternalistic, where the doctor would tell the patient what they thought they should do, and the patient complied. Now it's become more of a partnership where patients play a much more active role in healthcare decisions. So can you talk about this shift and then how patients can find an appropriate balance between being actively involved in all healthcare decisions and, on the other hand, trusting the physician's expert opinion?
So like you said, it used to be that medical care was very paternalistic. The physician was always the one with all the knowledge and the experience, and then the patient was supposed to just accept whatever recommendation the physician had. But as medical care has advanced, physicians and scientists are learning more and more about diseases that, like epilepsy, and the specialty and subspecialty physicians are learning even more and gaining even more and more experience. But as the internet has become widely available and more widely used, and as people are becoming more connected through social media, individuals with medical conditions such as epilepsy are able to do a lot more to learn about their own conditions. There's also social media allowing patients to be able to talk to others who are in similar situations and learn about the other options available. And so as a result, a patient going into a physician's office nowadays often has some background knowledge about their condition and all the possible treatments. And so for this reason, it's possible now for patients and physicians to be partners and to work together in their treatment. Another change is that as the medical care is advancing, there are more treatments available for epilepsy. In the past, there was maybe one drug available, and if you wanted to get better, you had to take that one drug and just put up with the side effects. But now that there are many drugs to choose from, the physician and the patient can work together to decide which drug or treatment would be most effective with the least number of side effects. But although individuals are becoming more knowledgeable about their condition, medicine in general is a complex field, and a lot of background scientific knowledge is needed in order to fully understand the condition and its treatment. physicians, go to school for many years to learn about the body and medicine in general, and then their subspecialties such as epilepsy in particular. And hopefully physicians stay up to date on the new research findings. So, even though there's a lot of information available out there, it's important to trust that your physician knows more about the best and newest treatments for your condition. In general, individuals seem to want to be involved in their epilepsy care to varying degrees. For example, I have patients who prefer for me to tell them exactly what they should do. The patient might tell me how he or she is doing, and I'll talk to him or her about the pros and cons of the different options. But in the end, some patients want me to just tell them what they should do. But on the other hand, I have other patients who will refuse any recommendation I make because of something that someone has told them on social media, or maybe something that happened to a friend of theirs. I think individuals know themselves better than I do, and at the same time, I have some idea of how they might react to different treatments, but they might have had experiences in the past that tell them about the particular way that they react to certain treatments. So I think it's best if a person can tell me about their own history and what works for them. But it's also good for them to trust me to give them options and explain the pros and cons of each option. And it's important that they trust that I have their best interest at heart and wouldn't be misleading them or making them to do something that would harm them. Right. And I think that's the most productive type of partnership that leads to the best outcomes for them.
Right. Great. So another decision that may need to be made multiple times over the course of one's epilepsy is what type of doctor to see. Can you talk about the various factors that determine whether a person should see a general practitioner or primary care physician, a general neurologist, or an epileptologist?
So there are a lot of issues to consider. Who you see depends on maybe how long you've had seizures and how resistant they've been to treatment. After a person has a first seizure, they might see their primary care physician first. That physician might order initial studies like MRI and EEG, and they might even decide whether or not a person needs to start on medication, or they might not feel comfortable ordering tests or treating seizures, and so then they might refer to a neurologist. And the neurologist they refer to is often a general neurologist. And a person might see a general neurologist if the seizures are easy to control on one medication. But then if a person continues to have seizures, then often a general neurologist will refer to an epileptologist. And an epileptologist has more knowledge about the different medication options, and that person might order more specialized testing or imaging studies. Now, if a person has seen a general neurologist or epileptologist and becomes seizure-free on medication, then they may be able to go back to seeing only their primary care provider. And if that person is comfortable with it, that provider can just refill their anti-epileptic medication prescriptions as long as they're stable and not having any side effects.
Right. And I would guess another circumstance under which it would be good to see an epileptologist would be if pregnancy is being considered.
Yeah, and that's often an issue that general practitioners, especially, but even general neurologists aren't comfortable handling. And like I said, epileptologists often know more about the anti-epileptic medications and their effects on pregnancy and childbirth and attempting to become pregnant. And so, often they'll refer patients to an epileptologist who are pregnant or planning to become pregnant.
Okay. And if a person has an opportunity to see an epileptologist for, fairly early in the process, even if they haven't, if they don't have intractable epilepsy or that hasn't been determined yet, is there a benefit to doing that just because of the additional experience and and the much lower likelihood that they would be misdiagnosed, and the much lower likelihood that they would put on an inappropriate medication. So is it something where if you have an opportunity to see an epileptologist, you might as well do that early in the process, or should people really wait until they're... Oh, go ahead.
Certainly if the option is available, if a person lives in the vicinity of a medical center that has epileptologists, then certainly even after a first seizure, we encourage people to come to our epilepsy center. Okay. We do a lot of individualized education for patients with new onset seizures and patients who have refractory seizures. But like I said, we provide a lot of education about the different medication options. And also we are more familiar with diagnosing epilepsy and telling the difference between seizures and other conditions. So it may be that a person was just passing out and not actually having seizures, and that's something that a primary physician might not be able to differentiate, and a general neurologist might not feel entirely comfortable. And in that case, an epileptologist would also be good.
Okay, great. If a person with epilepsy has a choice of insurance plans, like say their employer has multiple plans to choose from, or maybe they're seeking a plan through the health insurance exchange, or maybe they have multiple managed care options through Medicaid, but if they have a choice, what cost-related factors and coverage options should be considered when selecting a plan?
Yeah, so if it were me, I would choose an insurance plan that has a low deductible, and also good prescription coverage is important. Often one of the things we run into most frequently is people being unable to afford their medications because of high deductibles. So they might have good medication coverage toward the end of the year once the deductible has been met, but all of a sudden January comes around and their 1 month prescription is $400. So that's something to consider. And also individuals whose epilepsy is not well controlled are going to need multiple doctor's visits in a year, and may need more testing and medications. And if there's a high deductible, then that's going to get expensive. And so I think that deductibles and good prescription coverage are most important. Of course, if you can also get a low copay for the multiple doctor's visits that might be needed, then that's also a good idea.
Right. And how often do you run into insurance plans that don't cover other treatment options like surgery or VNS, or they don't cover advanced diagnostic testing or video EEG monitoring or things like that?
Actually, it's not too common that insurance plans just won't cover it altogether. There might be, it might be more or less expensive for the patient, but for the most part, we haven't had a lot of difficulty, except maybe with certain insurances getting coverage for video EEG monitoring or epilepsy surgery. Okay,
great. So let's go over some other common decisions related to the medical management of epilepsy that people may face and how to make an informed choice about each. So let's talk first about the differences between routine EEG, ambulatory EEG, and video EEG monitoring, and basically under what circumstances would each of these choices be appropriate.
Yeah, so which one is chosen would depend mostly on why it's being done. So routine EEGs typically last 30 minutes to an hour, maybe 2 hours, and they're done in the outpatient clinic. Usually they're used for someone who has new onset of seizures to look for any abnormalities that pop up on a short-term study. Many of the patients who have epilepsy or new onset seizures will have some abnormality on their EEG, even in between seizures, although some don't, and some people only have abnormalities during seizures. Routine EEGs are unlikely to capture seizures themselves, unless they're happening very frequently. Routine EEG might be done if somebody is thinking about coming off of medication or wanting to make changes to medications. Ambulatory EEGs are more prolonged studies. Usually they last at least 24 hours, maybe between 1 and 3 days. For those who don't know, ambulatory EEG is one where the patient will wear the EEG electrodes home. They'll go about their usual activities, driving and cooking and sleeping, etc., while the EEG is up and running. The ambulatory EEGs might be used to see if somebody's having frequent seizures that they're not aware of, or to see if there are significant abnormalities even in between seizures, and might be done also if a person is having frequent seizure-like events in order to determine whether or not they're epileptic. Video EEG monitoring is monitoring that's done from 1 day to 7 days or so while the patient or the person is in the hospital. Often that's done for the same reasons as the ambulatory EEG monitoring. But it's better in ways in that there's a video available as well as technologists who specialize in EEG and nurses available around the clock who can evaluate the person in the event of a seizure or seizure-like event. Often with ambulatory EEGs, one problem is that the electrodes can pop off, and if they come off during the study, then really nobody knows about it until the next day.
Right.
But technologists are available in the video with video EEG monitoring to fix the electrodes right when they come off. Video EEG monitoring usually is used to capture seizures. It's done if a person is considering epilepsy surgery in order to determine where the seizures are coming from and see if they might be a candidate for surgery. Also, video EEG monitoring is done a lot if a person is having frequent seizure-like events to tell whether or not they're epileptic or not. One other benefit of video EEG monitoring is that seizure medicines can be weaned under the supervision of people in the hospital in order to make a seizure more likely to happen. And it also might be recommended if a person is changing from one medication to the other. So there are a lot of different things to consider when choosing one of those studies.
Right. And presumably if someone has an ambulatory EEG, it's not safe or advisable to wean off medication.
Right, correct.
Right. And I have heard of some places offering video ambulatory EEG. Is that something that any of the comprehensive epilepsy centers do, or is it how commonly?
There are some epilepsy centers and some general neurology clinics even, I think, who have the technology to do ambulatory EEG with video. It's a little bit difficult because still you can't move the video around all the time. So usually somebody will come to the home, is my understanding, and they'll set up the video, say in the living room or in the kitchen or somewhere where the patient spends a lot of time, but can't go with them outside of the house or through the house.
Okay. So another common decision is how to choose an initial medication, that first medication. How is that done, and to what extent is that is the patient's input included, and are there situations where the decision is made without the patient's input, like, for instance, in an emergency room setting or things like that?
Right. So it's important the choice of the initial medication. We've done studies and shown that the first medication a person is put on is the one that they're most likely to stay on for many years or their whole life. There's always options to switch, but often it's that first medication that's stuck with. So for that reason, it's important to choose one that is effective and has the lowest number of side effects and the fewest long-term effects on the body. I would hope that most of the time patients would have input into what medication is chosen. A physician should go over the risks and benefits of each one and talk about the side effects. But one situation, as you said, where that might not be the case is when seizure medications are started when a patient is in the hospital or maybe in the emergency department and when they're critically ill and not able to participate in that decision-making process.
Right. And so what are the key factors? Obviously, side effect profile and potential efficacy, but what are some of the general considerations that you go through when you're making that decision, and how do you take into account patients' desires or concerns about the medication?
So, first of all, we go with a medication that's relatively easy to start and does not have too complicated of a regimen, usually ones that are have the lowest number of side effects if possible, and are given once or twice a day. Another factor is cost, and some of the newer medications or the newest medications are more expensive than older ones, and so that's something we need to consider. When I'm talking to a patient, often I'll go over the different medication options and talk about the most common side effects with each one, and how we would start the medication and what dose and what the procedure would be if they had more seizures on that medication. And often a patient will know kind of what side effects would be worse for them. For example, there are some medications that cause a lot of irritability and can worsen depression, and so that might not be good for a patient who tends to be irritable already or is already depressed. Right. And so a patient's input is going to be important there. Yeah.
Okay. So once the initial medication is chosen, or maybe you've even tried multiple medications, you may be faced at some point with the decision of whether or not to discontinue a medication, whether to add a new medication if the first one is not working, or whether to switch medications. How do you determine between those different options?
So medication changes would be made if a person is continuing to have seizures, or if their seizures are worsening, or if they're having intolerable side effects to medication. If they're continuing to have seizures, then a physician or neurologist or epileptologist might either choose to switch to a new medication and taper off the first one, or add a second medication to the first one. Usually that's a physician's preference and possibly also patient preference and how comfortable they feel going off the first medication. If a person's having side effects, then the physician would most likely choose to switch to a new medication. It's not frequent that a seizure medication would be discontinued altogether without adding a new one, unless the person has been seizure-free for a long time and wants to do a trial off of medication, or if they're no longer at risk for having seizures, such as with children who outgrow their epilepsy, a patient whose brain tumor has been removed, or other situations. Another reason to stop medication or switch to a new one would be if a person develops a new condition for which the medication is contraindicated. For example, a medication might be stopped or switched to a new medication if a woman becomes pregnant, or if a person develops liver disease, then certain medications would be contraindicated. Also, if the person needs to be placed on another medication which interacts with seizure medicine, then changes might be made then.
Right. Okay. In terms of seizure management, the decision of when to call 911 and also when to use a rescue medication, and if you're using a rescue medication, which one would you use? So those are questions or decisions related to managing the acute management of seizures.
Yeah. So 911 should be called if a person has never had a seizure before, obviously, and if that's their first seizure. Also, if the seizures are somewhat different than usual, and this is something new that the patient hasn't had before, then that would be a reason to call 911. The most common reasons that we recommend for calling 911 are if a seizure is prolonged, lasting more than 5 or 10 minutes, or if a person isn't waking up after a seizure, or if they're having back-to-back seizures. 911 might also be called if a person is having a seizure in a public place or at work, and those people around are concerned about them and don't know what to do. In general, if a seizure is not different than usual, if it's not prolonged, and if someone is not having back-to-back seizures, then 911 doesn't need to be called. Sometimes a physician might prescribe a rescue medication such as Ativan or Valium to a patient, especially if they are tending to have longer seizures or clusters of seizures happening back-to-back. And the medication can be given either during or after a seizure and can be used to stop a seizure from continuing or prevent further seizures from happening. After treatment with the rescue medication, 911 still often has to be called. So Ativan or Valium are usually the rescue medications that are used. They come in different forms, and that's the main consideration to make. So options for the forms for the medication would be a tablet or an oral liquid medication or a rectal suppository. So rectal suppositories are used most often for children. It's difficult to use for adults and kind of embarrassing for them. Mm-hmm. Usually the rectal pills would be given during a seizure in order to help stop the seizure. Tablets are usually not given during a seizure because a person isn't able to swallow on their own, but can be given after a seizure in order to prevent a new one or a second one from happening. And then liquid medications I'll often prescribe that can be given through a dropper when a person is having a seizure. The liquid is just inserted in between the cheek and the gum line by a bystander, and the liquid can also be used after a seizure in order to prevent another one from happening.
Okay, and can the dissolvable wafers also be used in that same fashion in a buccal application, like between the cheek and gum? Yeah. Okay.
Yep, they can. The one consideration would be it might be a little bit harder to get it during a seizure. It might be harder to get it in the mouth in between the cheek and gum, just because it's a larger thing that you need to insert.
Yeah. And then I know some of the pediatric epileptologists across the state are using intranasal Midazolam. Is that being used much in the adult population?
It's not, to my knowledge, being used too much. I know it's being studied. We participated in a study at Spectrum and to look at the effectiveness of intranasal Midazolam over other forms. And I think it can. I'm not aware of at this point the results of the study, but I believe that it can be effective and is a rapid way to administer the medication, and it gets into the system fairly quickly.
Okay, great. So that's something that adults could ask their epileptologist about if that was something they wanted to consider. Okay. Okay, so here's a major one: is if medications aren't working and you're considering other treatment options, it can be a very challenging decision to decide between resective surgery, where a part of the brain is removed, laser ablation, where a laser is used to essentially melt part of the brain, and that can't be safely removed. Or responsive neurostimulation, or the RNS system or the vagus nerve stimulation. Very, very different options, and obviously a lot of factors to consider when deciding between them. Can you kind of give an overview of some of the different considerations when choosing between these different options?
Sure. So a lot of the options, particularly the resective surgery, the laser ablation surgery or the responsive neurostimulation are used if a person has focal seizures or seizures that come from only one or maybe two areas of the brain. Vagal nerve stimulator can be used even in patients with generalized epilepsy where the seizures begin all over the brain at the same time. If there is an easy-to-identify lesion on the MRI, then that, such as a tumor or maybe scar tissue, then that lesion can either be resected with brain surgery or burned with the laser ablation. Even laser ablation requires some surgical intervention, but it's generally less invasive, and people may choose the laser surgery if they don't want to go through with a major surgery. Even if there's not an obvious lesion on the MRI, resective surgery can be done if other testing points to a certain area of the brain where the seizures are starting. Often we'll do intracranial EEG monitoring where we place electrodes on the surface of the brain and capture seizures that way and determine more exactly where a seizure is coming from. And if we can do that, then sometimes resective surgery is a possibility. Resective surgeries or laser therapies can't be done if the seizures are coming from a part of the brain controlling an important function such as speech, sensation, sight, or motor function. And in that case, the responsive neurostimulation, which is also known as neuropace, can be used, and that involves implantation of electrodes on the surface of the brain permanently through a surgery, and the electrodes are placed over an area known to be causing the seizures. The electrodes sense a seizure when it happens and then deliver an electrical discharge to the area where the seizure is, and that hopefully stops the seizures from happening or from progressing to a point where a person is at all symptomatic. So it's somewhat like a cardiac defibrillator. So those are used for, if those options are used if a focal lesion can be identified or an area of seizure onset can be identified. But if none of those options can be used, or if the patient is not interested in surgery or major brain surgery, then the vagal nerve stimulator can be considered, and that involves placing electrodes over the vagus nerve in the neck. So it's just a small neck surgery, and there's a battery pack that is implanted on the left side of the chest, and it acts like a pacemaker. So every 2 minutes or 3 minutes or however often it will deliver a stimulus, and that stimulus, it's not as well understood how it works, but that stimulus to the vagus nerve on a regular basis can reduce seizures. And that can be an option for patients with generalized as well as focal epilepsies.
Right. And for people who have more than one seizure focus, then in that case, then either the RNS or neuropace or the VNS would both be options, but typically the resective surgery or laser ablation would not. Typically
not, no. It depends on how aggressive.
If you have multifocal epilepsy, when you could have resective surgery?
Yeah, there are exceptions, and it depends somewhat on the institution and the epilepsy center and how aggressive the physicians are or like to be. So in some cases, if there are multiple lesions, then a combination of modalities can be used. For example, one area can be resected, another area can receive neuropace, or another area can be ablated. There are certain types of, certain areas of seizure onset where you wouldn't want to do multiple resections, such as seizures that are coming from both temporal lobes. You wouldn't really want to, it's dangerous to resect areas of both temporal lobes, for example, but it might be possible.
And can you also talk about the difference between like a temporal lobe resection versus a lesionectomy, where you're just removing the lesion itself and no surrounding brain tissue? So temporal lobe resections are fairly common. Temporal lobe epilepsy itself is fairly common, and when
when we do EEGs and MRIs, often we'll see scar tissue in one area of the temporal lobe, in the kind of medial temporal area where the hippocampus is, and that is often an area of seizure onset. But we don't often know where in the hippocampus or where in the middle temporal area the seizures are coming from. And so it's fairly common practice over the years to remove that whole area only on one side, as well as the most frontal part of the temporal lobe. And people have a good outcome from that. But in other cases, with the if there's a focal lesion, then that only the lesion itself might be taken out. Often during a resective surgery for a lesion, we'll put electrodes again on the surface of the brain and just see if we find abnormal discharges around the lesion, and so we'll take out the lesion itself and then the area where the discharges are coming from. But the lesion ectomy is usually typically a smaller surgery. Does that answer your question?
Yeah, so I guess with a lesion ectomy, is there a higher risk of seizure recurrence because there may be surrounding tissue that's been
correct,
that may not be the actual seizure focus, but is part of the network of neurons that are involved, basically?
Yeah.
Okay.
The best, really the more tissue you can remove and the more precisely you can identify where the seizures are beginning, the better the outcome for seizure freedom is.
Okay. So if someone is an ideal candidate for resective surgery, I'm sure you've come across this before, but they're hesitant to go through with it, what are some arguments for and against it that you might discuss with the patient? Surgery isn't for everyone. Even if a person is a great candidate and have a very high likelihood of seizure freedom, they may not be a good candidate just because of their own preferences or their own fears. So it's important to know that in somebody who has epilepsy, about 50% or so of people will become seizure-free with the first anti-seizure medication they try. Another 10% or so might become seizure-free with the second medication they try. But after that, the chance of seizure freedom with adding additional medications is very low. And so epilepsy surgery, one of the benefits of it is that if you can identify a lesion either on the MRI or through various techniques that can be resected, then there's a much higher chance of seizure freedom. For example, in individuals with temporal lobe epilepsy, if you can identify a lesion, then even if a person has failed multiple medications, then there's still an 80 to 90% or so chance of them becoming seizure-free, at least while they're still on medication. I guess one downside to consider is that a person who has epilepsy surgery, even if they become seizure-free, might not be able to come off of medication. And so if a person is seizure-free on medication, then epilepsy surgery might not be the most ideal for them. Right.
Epilepsy surgery obviously comes with its own risks. There's risks associated with surgery in general, such as bleeding and infection and other surgical complications. The RNS, or the responsive neurostimulator, is a device that it's permanently implanted in the brain, but every day or so a person needs to send data from the RNS into a computer program, and so that involves a lot of a time commitment, which a person might not be willing to do. But so I think that the biggest argument for epilepsy surgery is the much greater chance of seizure freedom, and there are certain complications of surgery which would be the main argument against it. And some people are more at risk for complications than other people. People who have had brain surgery in the past would be at higher risk of another surgical procedure, for example, than people who have not had surgery before.
Right. And to what extent does the potential impact of surgery or not having surgery on cognitive function play into the decision?
Right. So seizures themselves and the medications that are used to treat seizures can cause decreased cognitive function, especially if seizures involve the temporal lobes that can have a major effect on memory. So both surgery and medications and continued seizure activity can affect memory function. Usually we do testing before considering somebody for epilepsy surgery to see if they have any baseline memory difficulty, and then we do some other testing to determine what the likelihood would be of them having memory difficulty after surgery. So in somebody who has baseline memory problems because of their seizures, surgery is not likely to have much additional or cause much additional memory loss if done in the right way. But in somebody who's high functioning, is president of a major corporation or involved in academics, or is very bright person, might suffer a lot from certain epilepsy surgeries, and they might want to consider not having a resective surgery, but doing something else like the responsive neurostimulation.
Right.
Yeah.
Okay. So another treatment option is the ketogenic diet, primarily used in children because it's so difficult to stick to. But and then there are also two variants of that: the modified Atkins diet and the low glycemic index diet. If someone was interested in pursuing dietary therapies, what would how could they decide between those three different options?
Well, like you said, the diet options usually are not used in adult patients. The ketogenic diet especially is very restrictive. So basically all the diets involve eating a low number of carbohydrates every day and eating greater amounts of fats and proteins. The three diets are different degrees of restrictiveness in terms of how many carbohydrates a person can eat. So ketogenic diet is the most restrictive, and it's very difficult to stick to. It's difficult even for children to stick to if they're used to eating cookies and snacks and things. And usually in adults we don't even consider the ketogenic diet because it's so hard to stick to. The other options are less restrictive. And so if a person is very interested in one of the diet options, then those would be the two, one of the two to consider. But the diet options haven't shown to be very effective in adults. Even the ketogenic diet is not as effective in adults as it is in children. Okay. And so it's not something that usually we recommend. If a person is very motivated to be on fewer medications, or if they are having very difficult to control seizures, then that might be something else to try.
Okay. And along those lines, if a person has tried everything and nothing has worked, they're not a surgical candidate, no medications have worked, when should a person consider complementary therapies, and then how do you assess their potential risks and benefits and whether they're safe to try?
So I think complementary therapies can be considered at any time, depending on the individual and what their preferences are. Some people are able to tolerate medications and are willing to take more medications than other people, for example. And there are multiple different complementary therapies that I'm sure I don't even know all of, but there's certain herbal supplements acupuncture, chiropractic manipulation that have been used, and other forms of spinocranial therapy. In general, they have not proven to be very helpful for patients with epilepsy. I think when we think about complementary therapies or natural treatments for epilepsy these days, everybody thinks about medical marijuana, and so that's maybe the thing that gets asked about the most. There are a lot of anecdotal stories about patients who have become seizure-free or have had a significant reduction in seizures with medical marijuana. It's not something that's been widely studied. There are a few studies that were done more in past years that showed varying results or degrees of effectiveness. I know there are studies underway looking at certain forms of marijuana. But other than that, there's not been much research done on other forms of complementary or alternative medicine. But it's always something that can be considered. I would prefer that a person consider it in addition to taking their seizure medications instead of as an alternative to.
Right. Okay, and then lastly, in terms of medical management of epilepsy, the question of when to consider weaning off medication. How did you make that decision?
So if a person has been seizure-free for some time, then that would be a time to consider coming off of medication. It might be reasonable if there's reason to believe that the person is not at risk of seizures anymore. Usually this is the case in children, as children are most likely to outgrow their seizures. Typically, teenagers or young adults or older people don't outgrow their seizures, or they don't go away unless the cause of the seizures has been fixed or taken care of, such as people who have undergone epilepsy surgery or people who have had a brain tumor removed or something like that, and there's some reason to believe that that they may not be at risk of seizures anymore. Usually, if somebody's considering weaning, then we'll have them have a repeat EEG, as I mentioned, and if the EEG continues to be abnormal, then that would be a good sign that they're not a candidate to come off of medication. Also, if a person has been seizure-free for a long time, but they still have a brain lesion, such as scar tissue or a small tumor or something that is benign but maybe provoking the seizures, then they would not be a good candidate to come off of medication. If somebody has in the past tried to wean medication or has taken themselves off of medication and has had a subsequent seizure, then that's a good sign that they need to stay on medication. But the main situation where we think about weaning is if a person has been seizure-free for some time and they don't have any particular reason that we can find to be having seizures.
Right. And I would imagine the point or their life situation at the time plays into it as well. For instance, someone who's just started college and just got their driver's license may say, well, maybe I don't want to try weaning right now. Maybe push that back a little bit. So, but somebody who drives for a living or it might not be a good candidate. Whereas if somebody is retired or living in a situation where they're supervised regularly, then that might be a better option. Sure. Okay, now I'd like to move beyond medical management of seizures and discuss some common decisions related to just daily living with epilepsy. So just kind of reference this, but the decision to drive or not to drive, can you talk about how you talk with patients about that decision?
Yeah, well, first of all, the easy answer is that according to Michigan state law, a person is not allowed to drive until they've gone 6 months without a seizure or actually without any episode of loss of consciousness. And each state has their own rules and regulations and time frames. And in Michigan, it's up to the patient to follow this rule. and it's not typically reported by a physician, except in certain cases. When we talk about whether or not to drive on top of being seizure-free, we have to realize that medications sometimes can cause side effects that make it dangerous to operate a motor vehicle. For example, they can cause drowsiness, or they might cause some memory problems that might make it dangerous to drive. They may slow reaction time somewhat, which can be an issue. Seizures themselves, or sometimes the conditions that cause them, such as a stroke or a tumor, can also have effects on cognitive function, and again, maybe cause slowed reaction time or episodic confusion, might make it dangerous to operate a motor vehicle. So all of this needs to be considered. If there's some question about whether or not a person is safe to operate a motor vehicle when they've been seizure-free, then I typically recommend that a person undergo a road test, which is either available through the Secretary of State, or certain rehab facilities might have testing available for that as well.
Right. And in situations, I imagine some neurologists are completely by the book and 6 months seizure-free, absolutely no flexibility on that, and then others may consider other circumstances. For instance, if someone only has a history of only having nocturnal seizures, or someone who only has ever had simple partial seizures that don't affect awareness,
right.
Or someone who has reliable auras, I guess to what extent do you consider those kind of factors in deviating from the actual law?
Yeah, and the law is actually seizures with loss of awareness or impairment in consciousness. But yeah, it kind of varies by the physician what the recommendation would be for the other cases. So seizures that happen only nocturnally, often neurologists will make an exception for that. What worries me about that is that you never know whether or not a seizure might happen during the day, and so that makes me hesitate to say it's okay to drive if you're only having events while out of sleep. I think it's okay to drive if a person is only having auras where their consciousness is not impaired, and they've been observed by people during a seizure, and they can vouch for the fact that they don't lose consciousness during a seizure. So if they've only ever had auras, or if they've only had focal seizures, maybe twitching in one arm or something like that, then I may make an exception for that if they've proven over time that they are not losing consciousness with their seizures.
Okay. Decisions related to pregnancy. I know this is a particular interest of yours. Can you talk about how you counsel patients who are considering pregnancy and not sure whether or not they want to go forward with that, and what types of considerations you discuss with them?
Yeah. So it would be very rare, if ever, that I would advise someone not to become pregnant.
Right.
One of the main considerations to take when thinking about pregnancy and epilepsy is medication. Certain medications, more than others, can cause birth defects, and certain medications, more than others, should not be used during pregnancy. And so if somebody is on a medication like Depakote, which is very likely to cause birth defects, then I would advise them not to become pregnant until they come off of the medication. Some people have a hard time doing that if that's the only medication that's ever worked for them. But so usually if somebody is attempting pregnancy, we will look at their medications and make sure that they're on medications which are safe in pregnancy but still effective. and in addition to birth defects themselves, certain medications can have cognitive effects on the baby later in life, particularly Depakote again. And so that's another thing to consider when making medication changes. In general, other medications do have risks of birth defects, but a much lower risk. And seizures themselves can be dangerous, and especially grand mal or generalized tonic-clonic seizures can cause changes in the body that can lead to loss of the pregnancy or stillbirth and cause multiple other problems. And so, in general, we never recommend coming off of medication entirely. And so it's sort of weighing the risks and the benefits. And so in the past, it was recommended that a person should be on the lowest number of medications possible, and that's still the recommendation that a person be on the fewest medications possible. Although that said, seizure freedom is still important. And so when somebody is pregnant, also one thing to consider is that the levels of the anti-epileptic medications can vary a lot, and so frequent monitoring of the pregnancy and of the drug levels and of seizures is going to be important.
Okay, great. Another decision that people sometimes are faced with is whether to pursue employment or apply for Social Security disability benefits. And again, that's a topic in itself, so we won't talk too much about that. But what in general do you talk with patients about when they're considering that sort of decision?
Yeah, so I mean, in general, we always encourage people to seek employment and maintain employment if at all possible. Certain jobs are more require a higher level of functioning than other jobs, and so that's an issue. Sometimes, seizures can impair memory and sometimes impair judgment and cause and medications and seizures can cause cognitive slowing, and so if a person's not able to perform their usual job or is not able to perform a number of jobs, then that might be a reason to apply for disability benefits. Also, if a person has cognitive deficits for some other reason. Or if a person is having very frequent and disabling seizures, then that would be a reason to apply for disability.
Okay. Neuropsychological assessments, when and where should you seek one of those? Obviously, pre-surgical evaluation, that's part of it, but if someone, for instance, just is having some difficulties with memory or other cognitive functions, how do they make the decision to seek a neuropsychological assessment?
So neuropsychological testing is often done if anybody has any memory complaints. So a lot of times the memory complaints are related to the epilepsy or to the medication. If anyone who has a significant memory complaint, whether it's obvious to other people or not, I would refer them over for neuropsychological testing, and that testing can sort of differentiate between the different possible causes of memory loss. It can determine whether the memory loss is mainly related to mood or depression, or whether it's medication related, or whether it's related to the epilepsy, or whether it's related to something more serious like a dementia. And usually neuropsychologists are part of neurology groups, and usually we would refer for neuropsychological assessment within our own neurology department.
Okay. And Are neuropsychologists obviously an advantage of seeing a neuropsychologist within a comprehensive epilepsy program or a neurology department? Is that they're more familiar with epilepsy and the common types of cognitive problems associated with epilepsy? But is it also true that some of them, some neuropsychologists within comprehensive epilepsy centers focus almost exclusively or mostly on pre-surgical evaluation and less so on just the general day-to-day aspects of cognitive function? And so is there a trade-off? In our epilepsy center, we have certain neuropsychologists who often perform a lot of the neuropsych testing for epilepsy surgery, but those people are in general familiar with the cognitive function in patients with epilepsy, and are good at knowing what cognitive complaints go along with what type of epilepsy and what type of cognitive complaints are related to epilepsy arising from certain different regions of the brain, and that can be helpful even if somebody's not considering epilepsy surgery. Okay, great. Also, another decision is when to seek a mental health professional. Obviously, everyone feels stressed from time to time. Everyone feels down or depressed from time to time. How do you determine, when that is a problem that needs professional help? And then how do you find someone? How do you choose a counselor or psychologist or psychiatrist?
And that's, it's really an individual decision when to seek out treatment. Obviously, from a physician standpoint, if somebody obviously is depressed or obviously suicidal, then it's very important for them to find a mental health professional. Even if a person is not depressed but just stressed, then it still would not hurt to see a counselor or somebody to talk things through with. I think probably everyone would benefit from having somebody professional to talk to every now and then. Depression and anxiety are more common in patients with epilepsy. It's kind of a part of the disease as well as the seizures themselves and the disability associated with them can cause more issues with depression and anxiety. And so anytime a person is exhibiting symptoms of depression or feeling down or is very anxious, then it's a good idea to seek out a mental health professional. I think that counseling with a psychologist would be the first step, and it's good if you can find somebody in a major medical center, especially one familiar with the effect of chronic illness, especially epilepsy, on mental health. And if counseling is not effective, then at that point it would be good to refer to a psychiatrist who can provide additional recommendations for medication therapy.
Right. Okay. Living situation is another consideration, whether you live alone, with a roommate, with a family member, in a group home or assisted living facility. What are the primary considerations in making that decision?
So I think the most important considerations there are, first of all, cognitive function, and second of all, seizure characteristics and seizure frequency. So as we've said already, seizures themselves and medications used to treat seizures and the underlying conditions that cause seizures can all affect cognitive functioning, and might make it difficult for a person to perform certain activities of their daily living, like paying bills or preparing food or driving or those sorts of things. And so for some people, living alone might not be an option just because they need a certain amount of help or a certain amount of assistance. a person is having frequent seizures or seizures that they're not aware of, then it's good to have some form of supervision. If they're not otherwise impaired but having frequent seizures, then it's good to have a roommate or somebody around who can recognize the seizures when they happen and possibly assist in the event of a seizure. And that person can also give rescue medication if necessary. And that is especially important if a person is not aware when they're having seizures. And then if a person is even more impaired, then something like a group home situation or assisted living might be better, especially if a person is on multiple medications and having difficulty keeping the medication straight, then that might be a better option for them to have somebody more closely supervising them.
Right. Okay, and lastly, some people have difficulty deciding whether or not to participate or let a family member participate in potentially hazardous activity. And obviously every activity is potentially hazardous, but certain ones are more so for people with epilepsy. I even had a guy who I talked with once who was really wanted to do scuba diving, and he had a long discussion with his epileptologist and eventually was able to do it and took appropriate precautions and everything went well. But how do you counsel patients when they're considering things like swimming or biking or climbing or even scuba diving, things like that?
So certainly, along with driving, we say no driving for 6 months following a seizure, but also we say take the typical seizure precautions after having a seizure include not swimming alone, not climbing to high places without some sort of protection, and not being around large bodies of water, and avoiding other situations where they would be likely to be harmed in the event of a seizure. After 6 months, or if a person has been seizure-free and well-controlled on medication, then the restrictions can sort of be gradually taken away and a person can become more independent. Bike riding is typically safe. If a person falls off a bike, then they're much less likely to hurt themselves or somebody else than if they were driving a car. And so typically there aren't any real restrictions for biking. But the more dangerous an activity is, the more important it is that they're well controlled on medication first and seizure-free.
Right.
It would take me a while after a patient has been seizure-free for me to scuba diving, probably.
Right. Okay. So I had some more questions, but we can possibly get to those if we don't have many questions from participants. But I do want to allow time for questions for our participants. So I'm going to go ahead and unmute the lines. Okay. So does anyone want to get us started with a question or a comment?
I have a question.
Okay.
My daughter just...
Okay. Go ahead.
Go ahead. I'll let her go ahead.
Okay, thank you. My daughter had the surgery in February. Left hemisphere surgery to remove part of the brain that causes the seizures. And I was just told yesterday that her doctor didn't do the full, I can't even pronounce the name correctly, but he didn't do a full surgery to remove all of the seizures. He just did a partial. And my question is now, what are the chances of her having seizures still after the surgery? She's been showing some like auras and a little bit of this and a little bit of that, but she's been seizure-free for the past 7 months. And now that we just had our visit, I'm just so nervous about her having seizures again after this surgery. I mean, you do the surgery and you think you're doing the right thing, and then I guess the question is, do the surgery completely heal a patient of epilepsy?
It can. So a lot of times people can't have the full surgery because maybe the seizures, like I said, are coming from an area that's important for speech or motor or something like that. But seizures are caused and occur because of abnormal electrical discharges that are occurring in a network, and sometimes even if you don't remove the entire area where the seizures are starting, but you remove just a part or most of the network where the seizures are coming from, then that can eliminate the seizures entirely. And I can't really say, a specific percentage of, how likely she is to be seizure-free. Probably the more that they can remove, the better. But the fact that she's been seizure-free for this long is a good sign, and she may be able to stay seizure-free. She's less likely to be able to come off of medications entirely, I would say.
Wow. Okay, guess I just have to, just keep praying and just keep hoping she doesn't have any more seizures. It's very, very frustrating. The doctor said she probably will be on medication, and she wants to drive. She wants to go to college. Her memory is messed up from the medications and the seizures. So she's not working or driving right now. She's at home trying to, get everything back together. Her verbal process is distorted, and so she's just at home now. We're doing therapy 3 days a week for memory and speech and language and physical therapy, and it's just, you just feel so helpless. Like, okay, well, why not do this therapy? She's still going to have seizures.
Yeah. And the farther out she gets, with all the hoping and the praying, the farther out she gets without having a seizure, it's more likely that she can at least decrease the number of medications she's on or the dose of medication she's on, and that might help her cognitive functioning. And obviously, the longer she goes without a seizure, she hopefully will be able to drive and be more independent. So hopefully that's the case for her.
Okay, thank you. I'm enjoying the phone conference. It's really enlightening.
Good. And Marissa, I believe you had a question?
Yes, I had a question. You had spoke earlier in regards to the medications, and you had made mention of herbal supplements. Now, what, in your opinion, are the herbal supplements that one can take, and what are the ones that one can't take?
I really don't have a lot of experience with herbal supplements, and so I might not be the best one to answer that. Any herbal supplements that are stimulating would and kind of excite the nervous system and wake up a person more would be bad ones to take. I don't believe that there are any specifically that are bad for seizures.
I think
as a
St.
general
John's
rule.
wort is one that is contraindicated, and that's an herbal therapy that's sometimes used for depression or mild depression.
For depression.
And that one is there have been some studies to show that can increase the risk of seizures. So that's the one that comes to mind, and then like you said, other Dr. Fabris, other ones that are stimulating in nature, things that some herbal supplements may include ephedra. I don't know if that's been outlawed or anything, but I know that's something that in the past used to be snuck into a lot of different herbal supplements, and that could definitely be a problem. So the most important thing is if you're considering taking something, that you make sure that your neurologist knows about it and approves it.
Okay.
But there really are no herbal supplements that have been demonstrated through rigorous trials to be beneficial for epilepsy.
Correct.
Oh, okay. Okay, thank you.
Okay, other questions?
I'm not sure, I didn't get your name, but you were saying your daughter had had surgery and it affected her memory.
Yes,
I'm not sure.
Carolyn. Yes.
Carolyn, hi. I'm Jenny. I had brain surgery 10 years ago, right? Nice talking to you and everything. I had brain surgery some years ago, and it did affect my memory some, but people can help you. It can help your daughter. My friend helps me, and, you know, you could get clues as to how to remember things, and it really can help. I know your daughter could go through things. She'll be able to make it. I know she will.
Thank you so much. So we're doing everything we can. I mean, reading, writing, playing cards, games, and like I said, she's in therapy. You know, it's just so frightening. You know, it's still very frightening.
Right.
It is. It's so scary. It was for me, I know, but I'm so glad I went through it, and it really helped.
Well, congratulations to you, ma'am, for being seizure-free. That is a good thing. Congratulations. I'm praying that my daughter can stay seizure-free, and she can have a good
Thank you in my prayers.
Thank you. You as well. Thank you so much.
Not bad.
Okay.
I had a question, though.
Yeah, go ahead.
I can't find it. You were saying that some medications can cause depression. Which ones? Because I sometimes feel depressed. I mean, everybody does it, you know, every now and then, but any particular medicines that can cause it?
You know, depression and suicidal thoughts are a warning on all anti-epileptic medication. And so anyone has the potential to do that. Certain ones, like Keppra, is the biggest offender as far as causing depression or mood swings. Also, medications like Topamax can cause some depression and kind of just dumbing down of your thought processes. Zonisamide or Zonegran is another one kind of in that same class. There are certain medications that are better for mood, such as Depakote can be used for mood, or Lamictal, or Tegretol. And so it depends, but really depression and mood changes can be associated with any of the seizure medicines.
Wow, I would agree. I would agree with that.
It does. I think you're right. I really do. Thank you.
Yeah.
One other question about the memory loss. That frustrates me. You said something about a neuropsychological testing and about moods and depression and everything. Do you know if I had a test like that, do you know if the insurance could pay for it?
Yeah, insurance usually.
They will. My daughter has one. They will. My daughter had that. She's getting ready to go back and have another one. My daughter's had 3 this year. Your insurance will pay for it. She has to go have another one next month.
Yeah, as long as you have any type of memory problems, yeah.
I do.
Yeah.
Thank you so much, everybody. I hope everything goes well for everyone. I really do. Thank you.
Okay, thank you.
Any other questions from anyone who hasn't had a chance to ask a question yet?
About the medical marijuana?
Okay.
And how does that combine with other medicines that I take?
Oh, that's a good question. Yeah. What do we know about interactions with medical marijuana, or in particular high CBD strains or high cannabidiol strains of cannabis? How does that interact?
You know, I don't.
Yeah, go ahead.
I believe it does interact with some of the anti-epileptic medications, just in the way it is metabolized. It's metabolized in the same way as some of the other anti-seizure medicines, and so it can affect the levels of the different seizure medicines. And so if it was something that you were thinking about using, then it's important to have your provider follow your other anti-seizure medication levels.
Back later.
But I'm not aware of any other interactions other than the fact that cannabidiol or marijuana can cause some cognitive changes, and so so it can kind of add to whatever cognitive changes you might have with the anti-seizure medicines.
Okay. Other questions?
I take Keppra, the Lamictal,
Tegretol XR, Risperdal, and Clonazepam.
Wow.
And all of those medications can affect your memory and your functioning, and your ability to work and drive, and so yeah, that would be an important thing to consider with the addition also of the medical marijuana. And I can't say whether or not medical marijuana would be better or worse than for the memory anyway than those other medicines.
Okay. Marcia, you had another question, follow-up question?
About the medical part of having part of the brain removed. Would that be a better option?
A better option than what?
Than medical marijuana. Well,
taking the medical marijuana.
In general, if you're a surgical candidate, it would be better because there's been a lot more research done on brain surgery as opposed to medical marijuana. But
yes.
But if you're not a good surgical candidate, then possibly that's the point at which you might consider medical marijuana. But it's Dr. Fabris, did you have anything to add there?
No, that was basically what I was going to say. It really depends on the individual and what type of epilepsy you have and whether or not you're a good surgical candidate.
Okay. We have just about a minute or so left. Does anyone else have a question? All right. Well, I think we'll go ahead and wrap it up. And Dr. Fabris, I want to thank you so much for your time and for sharing your expertise and very enlightening call. And hopefully people have a lot to consider when they are faced with their next decision and are more comfortable, talking with their doctor about it. So thanks everyone for joining us, and talk to you hopefully next month.